Our final paper in this session is the runner-up, essentially. We're giving an honorable mention to this paper because we felt it was really strong as well for the best paper award. It was not the winning paper, but it was a very, very close second. And so we do want to recognize Jolina Leader and Abby Gooderham for this paper entitled Perspectives on Telehealth Projects in Northern Communities, Lessons Learned for Decolonized Participatory Design and Assessment. And Jolina, I assume, yes. Okay, screen sharing is just starting, you're ready to go. So yeah, very deserving paper. Like I said, very, very close between this and the award-winning paper. And so we did want to also recognize your work as well. So please take it away, Jolina.
Wonderful. You can hear me okay? Perfect. Well, I just want to thank you so much for having me here today and for the honorable mention for the Best Paper Award. My co-author, Dr. Abby Gooderham, and I are overjoyed and greatly appreciate the opportunity and also being a part of this conference. And so I come to you today from Saskatoon, Saskatchewan, on Treaty 6 territory in the homeland of the Métis, and with joint affiliations with the University of Waterloo and the University of Saskatchewan. So our presentation today explores perspectives on telehealth projects in northern communities and the lessons learned for decolonized participatory design and assessment. And so there's this whole body of literature out there that identifies major gaps and problems when technologies are parachuted into communities. And that is when technologies are designed, implemented, and assessed with little or no community engagement or involvement. And so this is problematic, of course, because communities are often not driving the actions or decisions around technology projects. And so in design, often the approach, despite how well-intentioned it might be, is based in Western design principles and suited for different contexts and needs. Technologies are designed and developed from outside, created for communities rather than with them. Implementation planning and decisions for what will work best for a community are made elsewhere without real consultation or understanding of community realities, the spatial or infrastructural considerations, as well as needs. Assessment approaches leave out community voices and perspectives. The metrics and measures are often not created with or by communities, but instead reflect the values of those outside of that community. These are often based on westernized or colonized assessment approaches that tend to oppose the important idea of nothing about us without us. That is critical for Indigenous rights as well as Indigenous self-determination. And so today I'm going to talk about one particular study, which is about accessing healthcare services in northern communities. And previous studies have identified several access challenges, including the shortage of physicians and healthcare providers, often resulting in understaffing and limited access to healthcare services. Many northern communities often had limited infrastructure with fewer services, often with the concentration of services in urban or southern centers, which means long travel distances for patients to go see a doctor or specialist. And this, as a result, is increased costs and time away from their families. It sometimes might mean, taking time off of work or arranging for daycare, and that can be problematic in some cases, or just can't get that time away. Poor weather, road conditions, and limited transportation options can also further impede that access. And so these unique challenges in accessing healthcare contributes to significant health disparities. And these studies often, in this case, have shed light on the need for effective and sustainable solutions to fill healthcare gaps, and have pointed to telehealth as a possible solution for meeting the needs of communities. And so while telehealth itself is promising in many ways, there's still a major gap in understanding how well it is working for communities from their own perspectives. And so the reality is that technologies are often introduced into communities with little follow-up. And so in recognizing this gap, I explored community perspectives for building capacity in accessing healthcare. And so I'll share some insights from this community-based research project and use the findings of the study to investigate the potential for a different way of designing with communities. And so what are we talking about? Briefly, telehealth is a means of delivering and accessing healthcare services and information across distance. And it comes in a variety of forms. And so this study focused on traditional video conferencing telehealth units, as you'll see on the screen there, as well as two different types of remote presence robotics, including a remotely driven as well as a handheld unit. And so these are the kinds of technologies that we're talking about today as well. And so this research is informed by science and technology studies theory, and specifically a mutual shaping lens for understanding users and community perspectives, and the intersections between technology, culture, and society. And this work highlights how technologies are embedded within these social, cultural, political, and historical contexts, and that they must be examined within those same situated contexts that they're placed in order to better understand the roles, the functions, as well as the meanings that they might produce. And so mutual shaping emphasizes the co-construction of multiple social and technical actors by accounting for the role of human and non-human actors. Importantly, there are intersections and compatibilities with Indigenous knowledge and these ideas or concepts in STS, specifically the epistemological beliefs about relationality and agency of human, non-human, and ecological worlds. Moving one step further, STS can help conceptualize a needed Indigenous technology studies approach that can better inform technology adoption and use within Indigenous contexts and across epistemic cultures and knowledges, and moving beyond Westernized approaches. There's also a gap in understanding how Indigenous knowledge shapes science and technology, and the application of using community-based approaches to understand further. And so we wanted to understand from community-driven perspectives whether telehealth projects were working out, building off of existing relationships of over, I would say, about 7 years, talking about healthcare access, talking about education access in various areas, and discussions with these communities. We built a collaborative project that was developed to better understand what telehealth means for these communities. And so this was a collaboration with 4 Northern Saskatchewan communities. It's really a snapshot of perspectives from community members and stakeholders that are working with the communities or in the community, including the communities of Wollaston, Hatchet Lake, Dene First Nation that you'll see highlighted on the map, as well as the northern villages of Isle La Crosse, Pinehouse Lake, and the town of La Grange. I also collaborated with the Northern Intertribal Health Authority and regional telehealth coordinators who provided guidance on the project, as well as the knowledge users working directly with the communities that could use the research in ways that can help benefit those communities. And so during this time, there was very little evaluation of how well the technologies were working from community perspectives. And this study was an opportunity to really address those gaps. And so discussions with communities reinforced the need to work directly with them in order to assess this. And so to better understand what telehealth means for Northern and Indigenous communities, this project aimed to identify the strengths and barriers for utilizing telehealth. The personal accounts and experiences of telehealth users were explored using qualitative methods, so including in-depth interviews and semi-structured interviews and focus groups, and using grounded in community-based research approaches as well. So working with communities, creating support and collaboration, and then working with people in person. At the time, this is pre-COVID. So, and then we had a thematic analysis using a socio-technical mapping approach. It was conducted to draw out the meaning making and better understand community perspectives on technology use. And so this is the idea of mapping out and analyzing relationships between themes and the various actors involved. And so the findings revealed that users and technologies play significant roles in mutually shaping telehealth care practice. Through discussions, important strengths, but also challenges with using telehealth were frequently described, highlighting the lack of community involvement in the design, the implementation, and the assessment stages. And I'll share the main themes and some key examples that illustrate this. So the first theme, collaborative and shifting roles, shows how telehealth enables new forms of collaboration and shifts roles and practices in new ways. Local providers spoke about taking over for the doctor's physical or hands-on assessments, where the nurse was the eyes and hands of the doctor. Well, this expanded nurses' scope of practice, enhanced collaborations, and increased their involvement in the circle of care. It came with benefits such as having nurses with local knowledge, building community trust among community members. It also meant increased responsibilities and changes in work practice. One healthcare practitioner said, "We are on a remote northern community, so each staff has multiple roles. Myself and another staff member are the ones that make sure that everything is in order and everything is set up. And we have limited training on it, like how do we get it going and a little bit of troubleshooting for the telehealth unit." And so they spoke about this need for an ongoing training with using the systems to enable better use of the system or the telehealth units themselves. Telehealth coordinators and IT personnel were actually really essential for this, but in many cases, and after talking to the e-health advisors and whatnot, the positions were really not, due to the pilot nature of the project, they weren't actually in these positions early on and were left to the clinical staff to be able to sort it out at that end. So really better implementation planning was clearly needed. And that examines the resources and the training that would be needed and being able to model it that way. So in the second theme, technologies shape users' practices in enabling and constraining ways. Users adapt and reconfigure the technology to suit their needs. There are several examples where users would tinker with the technology when they encountered a problem or if it didn't fit what they needed. A perfect example was when a telehealth coordinator lobbied with eHealth Saskatchewan to create a modification to their existing system for spontaneous consults, as they were all scheduled systems. They needed this for their lactation consultant that needed to be, instant and spontaneous. And so she'd be able to use a laptop to connect in. And so this was a solution to address a problem with or a limitation of the scheduled systems. And so she said, the telehealth coordinator commented that it can't really be spontaneous. So she needed something to help with spontaneous consults and with the community because she's working with all of them. This really demonstrated the need for having flexible systems in place, and there weren't really any, and this created some challenges. Another main theme was place and space matters, which identifies where technologies are situated physically also matters. There were privacy concerns regarding where the telehealth machine was, specifically issues around even soundproofing or it being in a centralized location rather than in another part of the clinic. Local staff also found space limitations where they're housing the technology, especially with smaller clinics. And most of the sites actually lacked a dedicated telehealth room. So instead, it was often in a multi-purpose room, such as a kitchen or a boardroom. And staff would have to find another place for telehealth if they couldn't use it at the time. So to be closer to clinical equipment and computers as well. And so one healthcare provider mentioned that space is always an issue, space is always a problem. That's one of the barriers in this telehealth thing is if there's a baby clinic being held by the public health office, you're out of luck. You've got to go and find another site. She continued saying that oftentimes I've had it twice as an experience that we've had to move the telehealth screen to downstairs into the coffee room, and it's a really tight squeeze in there. So it shows you can't really design or implement technologies without knowing what the space or the place is like, or the people or the culture. And the assessment metrics have to take into consideration those needs. Finally, persistent socio-structural constraints for the implementation and utilization of telehealth were found relating to lacking or stretched human and financial resources, limited capacity in technology design and integration, among other aspects, billing and jurisdictional barriers. All of these shape how telehealth is implemented and used in healthcare practice. According to an e-health advisor who works closely with communities, he said telehealth coordinators are already a stretched resource. It just seems that we're stretching that resource. We could be heading for failure. Again, IT, it's a barrier. The findings demonstrate how technology design, implementation, and assessment needs to be community-driven, and technologies and resources must match community needs. As a study uncovered, when technology projects are parachuted into communities, they can create systems that do not work well. And there's a number of reasons for that. And so in our view, this really comes down to a lack of community engagement. Specifically, there's a current preoccupation or focus on increased efficiency and cost effectiveness, with less focus on users' experiences and perspectives. And there's a lack of community and users' engagement in telehealth design, in the implementation process, as well as the assessment. Additionally, there's little focus on the socio-technical implications of telehealth within those situated contexts that they're in. So asking questions, what does this mean for these communities and why is it important? The reality is, and the contexts are all really quite different. Northern and remote Indigenous communities who are reliant on telehealth for accessing healthcare services is very different than telehealth in an urban setting. Not only that, technologies are also often built in the South and adapted in the North, and we're not putting technology and decision-making into the hands of communities. So how do we address that? And so in our paper, we discuss the idea of a technology design continuum and suggest that we need to push design further towards decolonized model. So on the one end of the spectrum, we have traditional engineering approaches where technologies are primarily designed without users directly involved. Design teams have an imagined user in mind and try to fit the design to most users while leaving out some more minority users. With user-centered design approaches, designers work with users, and the focus is on designing for users, not necessarily with users, but it is moving in the right direction because we're asking questions about what are the needs of users. In participatory design, users know what they need. Users drive the design and figure out how it's going to be implemented with designers facilitating the process. The intention is still development that is led by design teams and assessed based on current practices or westernized principles. But if we really want to push participatory design further and want to be disruptive, then what would that look like? So decolonized participatory design, or DPD, could be this next step where users and communities actually drive the decision-making process at all stages of design, implementation, and assessment, and not just participating in it. It could mean users are designing and owning their own tools, their own processes, the intellectual property. In practice, it might look similar to participatory design, but they differ in their intention. So it's intentionally an act of disrupting that status quo to find real solutions. In DPD, decisions are in the hands of communities and in the hands of users, and it could mean, in some cases, the full rejection of the technology or the design altogether and having to scrap that and start over if it doesn't fit the needs or contexts. In that sense, it's an act of rebellion, resistance, and disruption. And so several studies point to the need for the adoption of decolonized participatory design and assessment models that consider broader socio-cultural and technical factors that inform Indigenous technology design, adoption, and assessment for longer-term community benefits. And so standard participatory design practice provides tools for decolonization in that it challenges existing power structures. It has a history of engaging local and marginalized groups and emphasizes mutual learning and co-creation. Decolonized participatory design integrates social justice design practices that seek to provide an equitable distribution of opportunities and resources to increase human rights and self-determination and protect the rights of Indigenous peoples. So it doesn't stop at participatory design. DPD is community-driven throughout the design, implementation, and assessment, and designers as facilitators, communities as leaders in shaping the design. In this approach, the tools are given away and IP is owned by communities. Implementation, again, is community-driven, iterative, and involves continual improvement. It means that there's no final design, and it means that it's ongoing and shaped by those who use it. Assessment is based on community-specified metrics, so it considers what success looks like in the community's eyes and how they get to decide who gets to assess it. Is it elders? Is it youth? Who's involved? And so we believe that decolonized participatory design is important as a next step to move technology projects forward in such a way that can serve communities in the best ways possible, as well as contributing to social and economic well-being. And that is it for me today. Thank you so much for listening, and I look forward to discussion.